provide medical, mental health, or any other type of health care service. The presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations of warranties of any kind, express or implied, about the completeness, the accuracy, the reliability, or suitability with respect to content. And just as a reminder, as we go through today's presentation, please put any question that you may have in the Q&A box, and we will answer at the end of the webinar. And we will also send out a copy of the recording in the next week or so. At the REC, we offer a variety, host of services to help meet both your outpatient and inpatient needs. This is a sample of the service lines that we provide. And as always, if you have any questions about any of our services, please reach out to us. We're happy to help. And we love to discuss our service lines at any time. The presenters today are myself, Vicki Harden. I am a Quality Improvement Advisor here for the Kentucky Regional Extension Center. And I am joined today by my colleagues who are also advisors for the REC, Jerry Deason and Vance Strakeford. Today we will be discussing what are MIPS Value Pathways, the MVP reporting, how to register for MVPs, identifying how to perform through a specific pathway, and then we'll take questions at the end of the webinar. All right, so let's get started. So what are MIPS Value Pathways? CMS has created this path to value. Their definition of value is the sum of quality of care that is being provided with additional outcomes that patients may have, divided by the overall cost of care for those specific services to be able to achieve those high quality outcomes. Historically, healthcare has been a fee-for-service industry, as we all know. So CMS has created a path for participants to transition from the fee-for-service industry to the value-based industry, in which reimbursement of services are based on those providers' effectiveness in preventing illness and promoting health. The path begins with traditional MIPS, which is what we all are kind of really used to. And it is the foundational layer of the quality payment program. And it focuses more on pay performance than pay for service. And then it stair steps up to the newly formed MVPs, which we are discussing today in a little bit more in depth. And then it transitions on up to APMs, and which is alternative payment models. The MVP is a bridge for practices to talk about specific episodes and types of populations. So MIPS Value Pathways are the newest voluntary reporting option that can be used to meet MIPS reporting requirements beginning this year, right now, 2023. And this is for practices and eligible clinicians. The window from MVPs to register for a particular pathway will be available sometime in April, and that registration will remain open until November of 2023. So why has CMS created this particular track? MVPs have been created to help move the process along from transitioning clinicians and groups who have been participating in traditional MIPS for the past few years into MIPS Value Pathways. And this is to improve the value of care. It reduces, it was created to reduce burden, inform patient choice in selecting specific clinicians, and reduces barriers to participate in alternative payment models. CMS looks at MVPs as a bridge to APMs. By reporting MVPs, it aligns you with a very focused cost measures, improvement activities, and quality measures that align with that particular MVP. Every MVP includes the foundational layer, which is comprised of a set of population health measures that you will select at the time of registration. And you would also have promoting interoperability measures that you would attest to, unless you have some type of special status or designation that allows you to reweight that category, which is the same as for traditional MIPS. So all of the different categories of traditional MIPS apply for MVPs, and anything that gets finalized in legislation for traditional MIPS for those categories, those same parameters will apply to MVPs. Okay, so let's talk about eligibility for MVP. Who is eligible? MVP eligibility is very similar to traditional MIPS. CMS will look at that same low volume threshold, which is greater than $90,000 on Medicare Part B billing, and also they'll look at 200 or more Medicare beneficiaries and 200 or more PFS services. The same form is the same thing for MIPS, for traditional MIPS. There will also be 2 snapshots for the initial and the final eligibility. The snapshot in November will be the final determination. In 2023, eligible clinicians and groups may report in an MVP in addition to traditional MIPS. Okay, so you can do both. An eligible clinician would receive the highest score attributed to their 10 MPI combination, with the exception of virtual groups. And virtual groups will always receive the group's final score. It is also important to note that eligible clinicians cannot report multiple MVPs for the same 10 or MPI combination. So each 10 MPI combination can only register for and report for only one MVP. And there are some that will be ineligible and cannot report for an MVP, and those are voluntary reporters, opt-in eligible clinicians, and virtual groups. All right, so here we see 4 categories with corresponding weights for traditional MIPS. Okay, it's going to look and feel, it's going to look the same way but feel very differently. The weights remain the same for MVPs and traditional MIPS. Any special statuses or scoring flexibility you can earn in traditional MIPS for a category will also carry over to MVPs, okay, which is good. Small practices and APM entities weights will align with traditional MIPS as well. Even though the category and weights are the same as traditional MIPS, looks a lot the same, it is different because they are made up of more aligned subsets of measures and activities. Okay. Quality and improvement activity categories have a menu of measures and activities that are relevant to the MVP that you choose. Each MVP has a list of quality measures to choose from, and the participant will select the 4 measures that best suits the practice. And it also, keep in mind, it will best suit the practice, the patient population, and the reporting method. Need to look at all 3. For improvement activities, the MVP will have a list of relevant activities for the participant to choose from, and then you will select the best activity for your practice. Cost is going to align with traditional MIPS as well. It's claims-based, so you would not submit anything for this category, and each MVP will have cost measures that are relevant to that MVP. Population health measures and promoting interoperability are foundational across all MVPs. Population health measures are selected at the time of MVP registration, and PI measures are the same as in traditional MIPS. So that's not changed. Just a note, CMS intends to adopt the scoring policies from traditional MIPS also. All right, so let's talk about the MVP timeline. So in 2023, this year, right now, will be the first year you can voluntarily participate in an MVP or report as a subgroup. Okay, so it's not mandatory this year. You can voluntarily report if you choose to. There is no anticipated MVP milestones for 2024. And then in 2025, this is the final year for voluntary subgroup reporting. Okay, so that makes 2026 the anticipated year for mandatory subgroup reporting. Very important timeline, just to understand where you are right now and where you need to be. Okay, and 2027 is the anticipated final year for traditional MIPS. Traditional MIPS will be sunsetting in 2027 is our anticipated year, but until future rulemaking comes out, we really don't know the specific year that traditional MIPS will be sunsetting. And as always, throughout the coming years, there's going to be more MVPs that become available. So now I will hand it off to my colleague, to Jared, to talk about MVP reporting.
Thanks, Vicki. Good afternoon, everybody, and happy Valentine's Day. I will talk here first about some MVP reporting. For 2023, there are 12 MVPs available for reporting. MVPs focus on a certain clinician specialty type or medical condition. This allows for more focused and meaningful approach to reporting compared to traditional MIPS. CMS will continue to expand this list to include more specialties and subspecialties that participate in MIPS through future rulemaking. So let's look at the ways that you can report. Similar to MIPS, participating eligible clinicians and groups can elect to participate in a variety of ways. The first way is at the individual level, and this does require that the individual be eligible for the program year in which they are electing to sign up for an MVP. The second way that CMS highlights is a single specialty group. This approach would be ideal for single TINs that is comprised of one type of specialty, such as cardiologists or even primary care providers. In this instance, the TIN or group would elect to register for the MVP and participate in the specialty group level for that MVP. Third approach is multi-specialty practice, or mainly for larger health systems. In this instance, a TIN may elect to identify one or more MVPs to participate in that is comprised of multi-specialties that perhaps make up the care team for the focus of that MVP. A few things to note with this approach. As Vicki mentioned, this is currently only available through the 2025 program year. And a clinician specialty is identified by their claims data. CMS is going to use the MPES taxonomy to identify what specialties your practice is billing, and that is going to be their source of truth. The next way to report is by subgroups. Subgroups are where a portion of the TIN may elect to submit to an MVP while the rest of the TIN elects to submit through traditional MIPS. Option 3 and option 4 are flexibilities that CMS has allowed for the smooth transition from traditional MIPS into MVPs. Finally, CMS has highlighted that APM entities may elect to submit as an MVP if it aligns. Similar to subgroup and their approach, this may comprise the complete APM or partial submission for that APM entity. So let's take a deeper look into subgroups. I wanted to spend a little more time here because this looks like what CMS intends to be the preferred submission level in future years. Subgroups are made up of 2 or more clinicians, one of which must be individually eligible for MIPS. Subgroups cannot contain any clinicians from a different TIN. Clinicians can only register for one subgroup, and they're recognized by their TIN and MPI combination. There definitely are quite a few different benefits when electing to submit as a subgroup. Subgroups aim to align and connect measures and activities across all performance categories to reduce the complexity and burdens for eligible clinicians. Subgroups also get more enhanced performance feedback for participants. They provide feedback for like clinicians reporting within the same MVP. CMS has also granted the flexibility through the program year 2025 that subgroups are reporting is voluntary. So now really is that time to get in there and get your feet wet with MVPs. This gives eligible clinicians sufficient time to implement workflow changes or system configurations that are needed to facilitate the subgroup reporting. To participate as a subgroup, the affiliate group must exceed the low volume thresholds at the group level. Subgroups will also inherit any special statuses assigned to their affiliate group. For specific category reporting, quality measures must be collected and reported at the subgroup level, which means the subgroup must be able to submit aggregated measured data just limited to those clinicians within the subgroup. For improvement activities, at least 50% of the clinicians in the subgroup must perform the same activity. Promoting interoperability is reported at the affiliate group level, and cost and population health measures do not require data submission as they're based off claims data, and this will also be done at that affiliated group level. If the affiliated group does not meet case minimums for either cost or those population health measures, they will be excluded from the subgroup's score. So in 2023, the CMS final rule, there were a few policy updates directed strictly at subgroups. We've mentioned it a couple of times already, but the voluntary reporting through program year 2025, then multi-specialty groups in 2026 will be forced to switch into subgroups, and that option will sunset. For 2023, CMS will look at the first 12-month segment of the 24 months MIPS determination period to determine eligibility against the low volume thresholds. Group 10s must provide a description of each subgroup that is registered. And these descriptions are not intended to be lengthy narratives, but they are expected to be a short description of the nature of practice and appropriately reflect the composition of the subgroup itself. Final scores. Each MIPS eligible clinician in the subgroup will receive a final score based on the subgroup's combined performance. CMS will not assign a final score for a subgroup that registers and does not submit data as that subgroup for the applicable performance period. If an eligible clinician does not submit using an MVP, they are still bound to those reporting requirements of traditional MIPS. Final scores will be based on the MVP reporting unless a higher final score can be attributed from another participation option, that being traditional MIPS or as an APM. As you consider reporting an MVP, it might be helpful to consider reporting both MVP and traditional MIPS in your first year to make sure that you do receive the highest score as possible. So what does the registration process look like? Here is a look at the MVP registration timeline. To report an MVP in 2023 performance year, you'll need to register between April 1st and November 30th of 2023. You'll also select if you plan to report as a subgroup during this process. You won't be able to make any changes to your registration after the deadline of November 30th. So definitely keep that in mind. If you plan to report the CAPS for MIPS survey that's associated with a specific MVP, keep in mind you must complete the CAPS for MIPS registration by June 30th. If you do register for CAPS for MIPS, you'll still have time to go in and edit your registration or subgroup registration until that November 30th deadline. So this is a little bit of a breakdown of the registration process. For 2023, at the time of registration, individuals, groups, or APM entities will select one MVP for reporting, one population health measure that's included in the MVP foundational level, and any outcome-based administrative administrative claims measures if they're applicable for the quality performance category. For subgroups, the registration is very similar. You will select all three of those, and with an addition of a TIN and MPI list that's associated with the subgroup to identify each individual clinician, and a plain language name and description for that subgroup. CMS will be putting out a registration guide sometime in the coming weeks to outline the steps needed to complete the registration in greater detail. I will now pass it off to my colleague Vance, and he's going to walk us through how to perform through a pathway.
Thank you, Jared. So let's start here, guys. I want to kind of walk you all through some scenarios and examples of, if you were a small practice, what you would need to do with the MVP. So this example that we are sharing with you here on the screen is looking at a small primary care practice that you have less than 15 eligible clinicians. So think of this as a small practice with less than 15 clinicians, or maybe if you're a single specialty practice or a small practice, or even a total tax ID that has one MVP pathway, or a larger practice with a subgroup specialty. So you can look at this example, and you're thinking about optimizing the chronic disease management MVP. This is one of the 12 options for 2023 for MVPs. So a small primary care practice, this may be a good option for them. They're looking at the chronic disease management option. So historically, they've always submitted the traditional MIPS using their EHR or ECQMs. They don't use a registry, a QCDR, or a qualified registry, but you have an option maybe through your EHR to have a registry for an additional cost. So those are kind of your background on this. For the MVP, for this specific one, there are available a few different options for the quality submission part. You can do it using Part B claims, your ECQMs, and or a combination of MIPS CQMs. So a registry and your EHR data can be combined for this one. You have options to either report as an individual or as a group. Those are your only two available options, either as an individual or as a group. There's no virtual group option for the MVP. So that's kind of the background for this, what you would want to consider as you're thinking about it. Now, as you move forward with each MVP, there is a foundational layer. So the first foundational layer in this specific example is you have to have a population health measure. You do have to select this at the time of your registration, where you're registering to submit for an MVP for the year. You will have to choose this. You have to choose one of these two options. Every MVP is going to be different. But this example, you have two options for a population health measure. And so here you want to look at either using the hospital-wide 30-day all-cause unplanned readmission rate for the MIPS groups, which is based off administrative claims, or you would choose the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions, and that's based off of administrative claims. So you want to pick one of those in this example, which you believe will be your best outcomes for the year. Now, we suggest that you look at historical performance data, how you have performed with these two measures in the past, to kind of give you an idea of what you will be setting yourself up for the performance year. So those are the things that you want to think about. There's also, you have to meet some thresholds, some minimum case requirements in order to be evaluated on the measure. If you don't meet that minimum case threshold, then you will not be scored. You would receive a score of 0 for this specific population health measure. And you don't want that happening. So you want to think about those things as you're deciding that. The next foundational layer category, so to speak, is that PI, the promoting interoperability category. Now, everybody should be familiar if you have been involved with the MIPS track for over the past several years. It is exactly the same as what you are used to as far as promoting interoperability. Now, the requirements change from year to year, but this is the exact same as the MIPS track will be that you would use, the MVP is. So you will still have to do your attestation statements like it says. Have you done an SRA for the year? Have you completed the SAFER guide? And do you have a certified ID, a cert EHR, those kind of things. So those remain the same. You will have the objective for e-prescribing in that query, the PDMP, that will be included, your provider to patient exchange objective, HIE objective, and then of course that public health and clinical data exchange objective. All of those are the same. You will still submit data like you have before previously. So the next step as you're considering the MVP in this example is your quality category. So you're going to have quality measures that you can choose from. Listed here on the screen in that chronic disease MVP, these are the quality measures that you have to choose from. You have to select 4 of these. So out of those options, this is what you want to select. And as you can see, in parentheses, beside each one of those options, it'll tell you if it's a claims or if it's MIPS, CQMs, or an ECQM. So think about that as you're deciding, do you have a registry? Then that would be the MIPS CQMs. And if you're using EHR data, that's an ECQM. So you want to choose the appropriate type of collection type in order how you receive data in order to when you're deciding these. So think about that. That will be very important too as you make those decisions. You want to choose 4 that you know or historically that you should perform well on. So you have to select them, consider those collection types. You also have the option as one of the measures to submit the CAPS for MIPS surveys as one of your quality measures. Now, if you choose that measure as part of your measure set, you still have the same deadline to register, June 30th of the performance year, as you do with traditional MIPS. And if you choose that measure, you have only until June 30th to make any changes to the pathway. That kind of shortens your time frame from November the 30th as you're used to. And I also recommend that you choose a backup measure in case you don't meet those beneficiary thresholds for the CAPS or MIPS survey, so it doesn't negatively impact your overall quality score. So those are the things that you would want to think about as you're choosing this specific MVP. The next is your improvement activities. Now here, it will depend, in this scenario, the example is a small practice. So you would only need to select 1 high improvement activity. Now, if you are a large practice, you have to do either 2 high or 4 medium. So, or a combination of things to get to your 40 points. So just keep that in mind. In this example, you would either select 1 high or 2 medium. And those are the different activities that you have to choose from. You cannot go outside of these improvement activities that are listed within the MVP. So if you think, oh, I want to do this chronic disease MVP, but I don't want to use these improvement activities that are listed here. I want to choose another improvement activity. You can't do that. You have to choose the ones that are selected. And that goes the same for the quality measures or those population health measures as well. So keep those in mind. You can't stray from what is already been established for the MVP. And then your cost measure. There's only one applicable cost measure for this specific MVP, and that is a total per capita cost measure, and that is based upon your claims. So it's nothing that you submit, you're just evaluated based upon that. So that is basically the pathway for that. These things that you need to think about when you're considering these things is if you are using claims, if that's what you are submitting data using claims, then small practices reporting quality measures through Part B claims, there's less than 4 measures that you can choose from. So you don't have to worry. You only have to submit on those 2 in that scenario. But just remember, you're only evaluated on 2 measures then. So you probably should be performing very well in those in order to do well. It's kind of a double-edged sword there if you think about it. You have less measures to worry about, but that also means you better perform well in both of those. And then of course you have your ECQMs. There's 4 ECQMs that are available, and then it shows here there's a combination that you could use from your MIPS CQMs. So the MIPS CQMs are like your registry measures, and your ECQMs are like your EHR measures. And you are able to combine those 2, but you can't combine claims in that. So just keep that in mind. So that was a small practice scenario. A lot of you all are probably work for larger health systems with multi-specialty practices that are involved. So this kind of talks about what you should do in that case. And, CMS is going to look at claims to determine what the service line or specialty time is and what MVP is going to best fit that clinician. And that's supposed to be released sometime around April, and it will be in the QPP portal. So CMS will determine that through claims, what clinician is deemed in what service line. So that'll be based upon their Part B claims, and that information will be released in April. So from our previous example, there's some additional levels of complexity that kind of builds from this previous example when you have a large multi-specialty system that's going to participate in MVPs. Because of your diversity of your clinician types, these organizations typically have all grouped under a single tax ID. CMS has kind of allowed for MVP multi-specialty reporting under a single tax ID number for this year, for 2023 and 2024, but they are encouraging those organizations to make sure that clinician types align with the MVPs, because once they are deemed a certain clinician type, they will have to kind of fall into that MVP that makes sense for that. For this year, they've developed 12 MVPs, like I said, and service line areas for these measures include there's primary care MVP, cardiology, neurology, stroke-related care, rheumatology, emergency medicine, oncology, renal care, and other wellness and preventative care services. CMS plans to expand these as the program continues and really evolves to reflect additional specialties and services. So this is kind of our foundation. They're starting off with 12, and they plan to expand those as we move throughout the program throughout the years. Now, CMS is also encouraging larger organizations to work on developing subgroups based on service lines or clinician types during the next few years because it's becoming mandatory in 2025. So if you aren't able to form subgroups for each service line with your tax ID number yet, but you kind of want to test the waters like Jared mentioned earlier, with more of a primary care or maybe a wellness focused MVP that you can align across multi-specialties, that you can break apart and do multi-specialty reporting while it is available, and kind of test that out without any repercussions if you don't perform well, but kind of get a understanding of the program, how this process works, would be a really good time. The measures within this specific MVP aren't really going to necessarily align with your emergency department clinicians, for example, or any other specialty areas, because they're not primary care or wellness focused per se. So what you could do is say that they are able to participate in the QPP. This is where forming those subgroups come into play, and you can form those subgroups within an MVP and form those within a 10. So consider what specialties you have within your 10 and what commonalities they share for possible multi-specialty reporting. But then identify those specialties that don't fit and would need their own MVP. So consider one that you can report data at a subgroup level for those clinicians that you've identified as being part of the MVP in the registration process that Jerry discussed. And two, if you have multiple 10s for your organization and clinicians provide care across both 10s, remember, you can't commingle data from another 10 when reporting through an MVP. So the same NPI can't report in a subgroup for tax ID number A, and that same NPI can't report for tax ID number B, for example. They cannot have B and 2. So just remember that. So it's going to be important to know how clean is your data. Is your EHR able to separate that NPI's data only in that 10? It's going to be very important. And a third thing that you need to consider is, do you have the capabilities to report for subgroups and keep that data separate? So like I just said, that's very important. And then probably the last thing is, what is your reporting mechanism? What do you have in place? How do you need to do this to support monitoring and reporting? Do you use a registry? Do you use an EHR? What's your functionality and capabilities within your reporting process? There's a lot to consider since you can't commingle data. And so this is something that you're going to need to think about as you start planning for this. And guys, I'm sorry, I forgot to advance the slides. I'm on this one right here. How do you prepare for 2023 and start to kind of dip your toes into MVPs? We suggest that you pick a subgroup of clinicians in your clinic, that you may have a cardiology practice in your 10, and that they are very engaged in quality improvement. You think they would be a good candidate for the Advancing Care for Heart Disease MVP. You could register those ECs under that MVP starting in April. Pick your population health measure and decide what quality measures for that MVP and start monitoring for performance. And then what do you do with the rest of your eligible clinicians within your 10 to make sure that they are covered for reporting? For now, you can still report through traditional MIPS for those. And for your group, you can report as a group level that also includes those cardiology ECs that are in the MVP. And that CMS will give you a group score like they always have. And if the ECs and the MVP score higher, then they're going to get that higher score. And if the MVP performance is lower, then those clinicians within MVP will get the group score if it's higher. So this option is probably going to be available as CMS kind of works to implement more MVPs, at least for the first couple of years. So now is why we suggest to do it, so there's no repercussions, like I said, to hurt that with you as you test the waters out. It's a lot of information. I know that. I've been talking a lot, so I'm going to bring my colleagues back in. So Vicki and Jared, if you'll kind of hop back on here and unmute yourself. We kind of wanted to know have a discussion between ourselves, how you would know if an MVP is kind of right for you. And so as you start considering those for your practices, there's a lot of different logistical items to think about. And Jared, I'm going to start with you and kind of ask and what you think about why is identifying eligible clinician types important as you select an MVP?
Yeah, absolutely, Vance. I definitely think it's important because it's where you should start when considering switching to an MVP. Look at the claims data of your providers and see where they fall and what their designation is based off that claims data. Sometimes there can be discrepancies on what you think your provider specialty is. So from there, I would compare it to the MVP specification sheets and see which best aligns with your clinicians and how many clinicians could participate in that MVP. And I think that's it, Vance.
Okay, yeah, that's great. Yeah, that's really important to have to consider that as you're choosing that MVP. Vicky, as people are thinking about, what are the right options, what might be right for them, where can they find that stuff, and what information and what measures and stuff is included? Where can they go to do that?
Yeah, so we've talked a lot about a lot in our previous slides about 12 MVPs. So where do we go to get more information on these MVPs? To look at their specifications and their reporting requirements. So you can find this MVP list on the Quality Payment Program, and all of y'all should be familiar with that. With the Quality Payment Program website, qpp.cms.gov, and all of you should be familiar with that website because, of course, that's where you complete your attestation. So you can review, and under that website, there is an MVP implementation guide that you can download. And within that guide, there is all kinds of information. It breaks down each MVP. It talks about their specifications. It's really, really good information. And that is you definitely need to go ahead and do that and start reviewing your MVPs. Now, if you're looking through your MVPs and you think, okay, there's not an MVP that is relevant to my practice, what do I do? Well, don't panic, because as we move toward this MVP track, there are going to be MVPs, newly created MVPs coming down the pike for practices to utilize. And just to throw this out there, there is also a MVP nomination process that is available for eligible clinicians and third parties and specialty societies. And this is to help develop new pathways for these practices that maybe currently don't have a relevant MVP right now. And this process can also be found on the QPP website. So valuable information on the QPP website. The resource library is a good way to find pretty much anything you need. So be sure and get on there, and let's start diving into these MVPs as soon as possible.
Yeah, good suggestions. I mentioned earlier too, and I just want to, it's here on this slide, so I'm going to mention it about reviewing your patient population to make sure your case minimums are met for quality measures. This is really important. The same thing for patient population health measures. Like I said a little bit earlier when I was talking, look at those case minimums. They're in if you go, like Vicki said, to the QPP portal, the QPP resource library, and look at those resources for MVPs. At the end of that MVP guide, there are appendices, and they list the 12 different MVPs and what each of the foundational layers are, the promoting interoperability, your quality measures. That's what we're talking about. Look at, make sure you review those, but they're also going to give you those case minimums, those thresholds that you have to meet. And if you don't meet those, something's not going to be reweighted to another category or another measure. You just get a 0 on that. You won't be evaluated, so you'll lose out on points. So you want to pick measures that you can meet those thresholds. So make sure you review that criteria and requirements for that. And as you start thinking about the different collection types for an MVP, that's really important. If you're using your EHR, and remember that's your ECQMs, or a registry, that's your MIPS CQMs or QCDR. So think about those as you're thinking about that. And I want to ask Jared to kind of discuss the different collection types and give us a little bit more details on those for us.
Yeah, so when you are thinking about switching to an MVP, let's keep in mind, let's think about the burden that comes to you as an administrator. How do you currently report for traditional MIPS? Are there enough measures within that specific MVP that you would not have to change anything? If you do have a registry, what's going to be that? If you do have to get a registry, what's going to be that cost of implementation for your practice? These are all questions to keep in mind. If you are a small practice, do you plan to just use the claims data? That can be pretty difficult to not know how you're performing midway through the year. So these are all good things to keep in mind. Vance, do you have anything more to add? I think you spoke so well to it in the previous slides.
No, I think you did a good job. It's really, we just, wanted to make sure we kind of reviewed it again with you all, because it is important I think some people just kind of go over that lightly. Oh, we have an EHR, so that's how we get our data. Well, what does that mean exactly? We're using a collection type for EHR. Well, it means there are certain measures that only EHR data is available for. So those are the kind of things that you need to think about. It's not that kind of correlates with the collection type and why that's important. So think about those things as you're doing that, and those thresholds, and whether you're considering the CAPS for MIPS survey measure, and those claims too. So think about those things. They all play a part, and sometimes we kind of just brush over that without really considering the magnitude that it may hold as you're deciding the MVP. And so as you're thinking about those collection types, Vicki, is there anything else that you can kind of talk about that would that they should think about as they're using registries or their EHR?
Yeah. So a lot of times, associated cost and labor contributes to the reporting burden. There may be some upfront costs associated with system updates or integration. There may also be administrative cost due to being able to report across multiple MVPs and multiple types of measures. So that is something to really consider on when you're talking about reporting through collection types. How are you going to drive that change, and what kind of systems are you going to put in place that kind of affects the labor that's involved in reporting for these types also, and what kind of accountability are you going to put in place for your data, and then monitoring that data that comes from the EHR is extremely important, especially when you're reporting subgroups. There's a level of complexity there, and once you start getting into subgroups, and so how do you pull that data apart to make sure that your data is valid? So there's a lot to consider. There's a lot of there are some costs, but there is quite a bit of labor that goes into reporting for MVP. So you want to start thinking about that also.
Yeah, I'm glad you said that, Vicki, because I think working with so many people across the state, reporting in EHR vendors or registries, that is a really tricky situation sometimes for how they can pull their data, or can they aggregate all their data across multiple sites? If there's providers that work at 3 of their 10 sites, can they pull aggregate all of their provider data into one report. All of this is going to come into play as we start this MVP, and you have providers that are in multiple sites, and like you said, their data can only be used for that one MVP only. You can't cross, Dr. Smith can't be used in this MVP for chronic care, and then, oh, we're going over here and he's also a cardiologist too, we're going to use him. No, that doesn't work. So just know that the reporting capabilities, it can be a little bit tricky. So now is the time to start practicing. Practice makes perfect, right? So I think it's really important as you guys kind of dip your toe. It's really easy to say, oh, we don't have to do that for 2 years and not do it, and then do it when it comes into play. It's mandatory. But if you don't try it now, it's going to be a much more difficult task to try getting ready for that. So this is why we're kind of suggesting to start now and get that practice in while it doesn't hurt you. It can only help you. So thank you all for discussing everything with the group, Vicki and Jared. Questions. We're going to quit talking, and if you all have questions, Vicki mentioned at the start of the webinar to please enter those into the Q&A box, and then we will try to answer as many as we can as time allows. And as you all are doing that, we're going to let you know about some upcoming webinars. So in March, we are going to be having our March the 14th from 12 to 1 Eastern Time. This is open to the public. We will be discussing understanding FQHCs and RHC eligibility for the Quality Payment Program. So many of you all may be in an FQHC or RHC. Check out that webinar in March, and then in April, we're going to be doing a little bit of a dive into quality and costs for QPP for this year on April the 1st from 12 to 1 Eastern Time. Now, this is a client only, so only our clients will get this information. So make sure you join if you are able, and to get a little bit deep dive into that. So let's go back up here to some questions. Let me look through my question and answer box. Let's see if we have any questions. We have here's one. Jared, do you care? This question is, our practice has both primary care and specialty services. Can I report just one MVP this year that includes all of our providers in the practice like we've done with MIPS?
Yeah, absolutely. I can answer that question. So there's a couple of different ways that you can report. For 2023, you can report traditional MIPS, just as you usually would, and you can submit for an MVP that aligns with the majority of your clinicians. CMS will apply the higher of those two scores for the payment adjustment. CMS does allow for multi-specialty reporting, but however, please keep in mind that CMS is encouraging practices to only report MVPs that are representative of all of their clinicians reporting to a particular MVP. I would really suggest whenever you do decide to switch over into an MVP, to do it during these voluntary years and get your feet wet and submit traditional MIPS as a backup just in case. Want to make sure you guys get the highest score possible.
Yeah, definitely. Looks like we have another one. Vicki, I'm going to pick on you now and see if with MVP no fault scoring, does that mean if I submit for an MVP, I will be guaranteed a positive adjustment for this year?
Unfortunately, no, it does not. It just means that you can register for an MVP, but not submit data, and you won't be penalized. You would still need to submit traditional MIPS and score above the 75 points to avoid a negative adjustment.
Okay, yeah, that was a good question, actually. All right, I think we're about at time. I don't see any other questions. I will thank everybody for joining us today. I hope you learned a little bit. We will be sending out recording to this to everyone the next week or so. So we'll be looking for that. If you have questions, just know that you can contact us here at our phone, our website, email. We're also on LinkedIn, Twitter, and Facebook. So please reach out to us or one of your advisors if you have questions, and we will be happy to try to answer that for you. Thanks again for joining us. Hope you guys have a great rest of your day and week, and we will talk to you soon.